So very interesting case. Nice patient in her mid-40s presents with what is a grade 3 capsular fracture on the left side. Saline implants from the year 2000. Back in 2000, you could only get saline implants because silicone implants were banned unless you were a part of a study. What's interesting is you could get it for reconstructive purposes. Now, as you will see on the right side, I removed this quite a bit of excess skin to help with the contouring and block the gold standard. And as you will see, if you look at it, I removed some of this inflamed, irritated, angry tissue on the bottom part. The fascia of the pectoralis major was removed in order to completely do what is this end block. Now, if you look at the left side and from this angle at the bottom, you will see it is raised. It is hard, and we're going to see the calcifications. Versus this one is flatter. What is overfilled saline implant. So I'm going to go ahead and cut this open, and I'm very happy. Minimal blood loss, probably like 3 cc's. Patient very well read. So I'm going to go in slow. Overfilled saline implant. Remember, saline implants are like a water balloon. You can overfill them if you will. There's a certain limit. Very good. It's a textured implant right here. And very thin. So remember, the goal is to remove all what is bad. And if I take this ruler and I put it in here, you will see how thin this is. No matter how thin the capsule, it has to be all removed. Because if it's not removed, we know, if you look at the Facebook Live from a couple days ago, why it is important to remove that tissue. And you can see it is a little bit weepy. So if you look at my glove, it's nice and dry. And look at that sliminess. I'm going to go ahead and pull this out. And you can see there's a lot of fluid around, not enough to send. If I go like this, look at this. This is that leaching, extremely slippery here. This is your McGann 270 cc implant. And again, if you look at this fluid. Hopefully in 2026 we're gonna send this off to a lab to assess. And so let's go ahead and look at our super thin capsule. Some areas so thin you can see my glove right here. Look at that. And overall, I'm very happy how this dissection has gone. You can see ultra thin capsule. And so now I'm going to remove my top sterile glove. I am going to use a sterile glove, new one for the left side. And we'll see exactly what is on the inside. Now there might be some fluid because remember it's raised and blocked, the gold standard, everything contained. It was hard dissection, and you can see not too far off from the implant itself. The other thing I want to show here is I removed more skin on this side to balance the two out. And you can see the scar tissue right here, and this is that aesthetic contouring. She was 5.2 centimeter from the nipple to the new crease, inframemory crease on the left and also on the right. So I balanced the two out. I did not touch the breast tissue. I don't like to cut into the nipple areola complex. And so anything inflamed, angry, irritated was removed. Now this is that calcification. So I'm going to go over here. Hopefully I'm able to get a better access. Look at all of this inflamed tissue. It does not look healthy and normal, and that's why it was removed. So all of it, as you can see, it's hard. It's inflamed. I want to enter. This is an intact saline implant, but I want to enter in a nice location without hurting the implant. So you're gonna I'm gonna go in here. Very calcified, as you can see. So you can see it's a different beast on this side. I'm going to go ahead and tease it out. And this is why the end block is key. Here's the valve, by the way. It's closed and sealed. I'm going to cut this off. Here's the valve. It's intact, as you can see. Calcifications present. I'm going to send this off to pathology. And you can see it's 270 McGann as well. And none of this spilled into the chest. No amount of, not enough fluid to send to cytology. You can see how it's flaking off. Someone will say, well, leave the capsule behind. You certainly don't want to leave that behind. 270, and it has like a sandpaper consistency to it. Look at these white flakes, if you will. And so if you look at the inside here, the goal here is look at how thin this is. No matter how thin, none of these, and again, look at this fluid. I'm going to just, it's not enough to send, but you can see how relatively viscous and thick this is. All contained, none of this spilled into the chest. And you can see no matter what, how thin it is, like here, you have to dissect in a meticulous fashion. No matter what, it has to be done completely. No capsule can be left behind. If anyone says, why remove the capsule, this is precisely why. And so, just gonna get a towel here. So, as you can see, there is a certain finesse into doing the surgery so that all the bad tissue is removed, contained, and blocked, not only the implant, but the capsule, but that inflamed tissue around, so that all of it is removed in what is that oncologic term, and blocked. None of this spills into the chest, that small amount of fluid, be it on the right or left. Only good, healthy, viable tissue remains behind. The implants will be returned to the patient. Capsules to be sent to pathology, rule out that rare BIAL, CL, CD30 analysis, rule out lymphoma, rule out malignancy, cultures for Arabic, anaerobic, and fungal. No need for that unnecessary lift in this nice 43-year-old lady. You have no need for drains. The blood loss, again, was like 5 cc's on each side, between the two sides. Altogether, between the skin and the entire dissection, 5 cc's on each side. And then twilight deep sedation. And a complete comprehensive workup, such that when we look back at this case, last week's case, last month's case, last year's case, last 8 years' cases, all of them have been done in a very systematic, thoughtful approach, such that when we look back at them, we could not have done it any better. And everything was contained. The last time I even used drains was over 6 years ago. And there you have it. 20 years from now, I cannot imagine anyone else doing this surgery any differently, because you have to have that all badness contained, and that is the standard that will continue to define itself in 2026 like it has in the last several years. This is Dr. Khan, Executive Plastic Surgery.